Good evening. I'll be skipping to the videos as so. This is a case of phacoemulsification. It's a grade 1 to grade 2 nucleus. Right from the start of surgery, I was unable to create a trench due to the soft cataract. I made a crater, and I found that the nucleus wasn't rotating properly. So at some point of time, there must have been a small rent, and I'm still trying to rotate the nucleus. Nothing is going as per plan. Please observe carefully. There you go. Momentary dilatation of the pupil with sudden appearance of red reflex, which says that we have created a rent successfully. At this point of time, what most people do is retract the phacoprobe and everything outside the eye, which creates negative pressure and prolapse of vitreous in the anterior chamber. We have to retain the phacoprobe inside the eye and put a dispersive OVD. Here what I tried differently is, since it's a grade 1 nucleus, I went ahead with a cutter. I used the side port that I've made for the infusion, and I've continued the surgery. The IOL, the rent did not expand. Since the rent did not expand, I finished the whole case with a cutter, and I've implanted the IOL away from the PCR in the bag. If you have a good capsular support, if you have a good anterior capsular rim, but a bad a large PCR, you can go ahead and put the IOL in the sulcus, a 3-piece IOL, and do an optic capture. But you have to, before doing that, make sure that there is no vitreous in the anterior chamber. You can use a triamcinolone acetonide to stain the vitreous and do a proper anterior vitrectomy, and you can place the IOL in the sulcus and do an optic capture for the IOL to be in a more physiological position. So basically, any secondary IOL is an IOL that is placed not at the same time of cataract surgery, but much later. It can happen due to pre-existing conditions or intraoperative complications. We have many secondary IOL implant options, most popular being SF IOLs and iris fixated IOLs. I think Dr. Jaya Madri is speaking about iris fixated IOLs later, so I'll be skipping that part. You can have a very good result with an iris fixated IOL, which she'll be showing you shortly. Scleral fixated IOL, the most popular one is the Gabor technique, where or the handshake technique described by Mr. Amar Agarwal, where the lens, where the IOL is placed in a more physiological position behind the iris. Just implant it in the bag, inside the eye, with the help of an intraocular forceps. Externalize the haptics on either side 180 degrees and just tuck them into the pre-made scleral pockets. A small modification to this is the Yaman's transconjunctival technique described by the Japanese ophthalmologist, where a 30 gauge needle is pushed under the iris and the haptics are tucked into the 30 gauge needle on either side. Both the haptics are externalized, and once they are externalized, cautery is applied to the tip so that there is slight deformity of the haptics, and these are then pushed towards the sclera. AC IOLs previously were thought as a bad option, and many people may have told you not to go ahead with ACLs. Yes, in the past there might have been a lot of complications because there were no PIs were not done properly or vitrectomy was not done properly. If it works in your hands, you can have good results with ACIOLs too. I have seen many ACIOLs doing well for the past 25-30 years. So if it works in your hands, you can go ahead, do a good vitrectomy, do a good PI. So it is the take-home message is anticipate the complication, recognize the complication early, so that there is no before you end up in more complications like a nucleus drop or something. Choose the right technique, the technique that works in your hands. Be honest with the patient. If he is immediately post-operatively, he may be fine, but he may land up in complication later. If don't hide, try to hide something. Talk to the patient if a complication has happened and how you have managed it, and under promise and over deliver. Thank you.
Thank you so much,